This is what I'm going to talk about today. And the reason I want to talk about this is because antidepressants have become the standard of care in our country, maybe the world. They're the go-to treatment for most people who come in reporting depression, right? I don't think that's a controversial statement. And I feel that for the non-drug treatments to have credibility, they need to be shown, the data needs to be exposed that show them to be as good as, if possible, or at least look at how they compare with what's the standard of care, okay? So that's why I chose this topic. I feel it's important as a psychologist, if I'm going to offer a treatment, that it should be seen favorably to what's the most common treatment for depression. My objectives here are to tell you a little bit about the epidemiology of depression, compare the treatments alone or in combination, emphasize studies that do that, come up with some simple behavioral prescriptions that are drawn from those data, and talk a little bit about what to tell patients about their choices. And I will emphasize choice throughout my talk. I don't want to tell anybody what to do. It's going to be choice based on the information that we provide, of course. Now, this is still a minority perspective, I think. And when I started talking about this 30 years ago, it was really a minority perspective. So I feel a moral obligation to present data. And I apologize in advance because I'll probably present too much data for a talk like this, but it's important. I feel I need to do that and not just try to convince you based on my winning personality. Okay, so this is why I include so much data. In an advisory, before I get started too, people do have a right to make changes in their medications, of course. But I don't want anybody to start or stop or change or increase or decrease any medication without consulting a prescriber. But let me add something to that, a qualifier, a prescriber who's willing and able to help you come off if that's what you want to do. So if any of the information presented here today causes you to think about making some changes, keep this advisory in mind, okay? It's important to do something like carefully and responsibly. Right? That's just the place to start. Of course, your daddy loves you. He's on Prozac. He loves everybody. And the truth is, these treatments have taken on mythical powers, okay? And so much so that it's infused into our pop culture. You know, many people think of these drugs as transformative and very, very powerful. And you see it in this cartoon. And in this one, it says, this next one is a sad little blues tune about love and pain that I wrote before I started taking Celexa. Okay, Celexa is one of the SSRIs. He's been really nice lately. I think he's taking antidepressants behind my back. Okay, so you get the theme, right? We think of these treatments as incredibly powerful. And it's maybe some part of it is advertising. It says, I'm having such a good time, I feel like we're in a pharmaceutical ad. But it's not just the advertising, as Dr. Healy has pointed out in some of his work. And the truth is, sometimes it doesn't live up to the hype. It says, I think the dosage needs adjusting. I'm not nearly as happy as the people in the ads. But it's not just the ads. It's also the studies that appear in the journals that we consume as providers and patients and so forth, okay? So this is a really important slide from a really important study done by a psychiatric colleague of ours, Eric Turner, from the VA and from the University of Oregon School of Medicine, and it bears a little bit of explaining here. This represents 74 randomized controlled trials that were submitted to the FDA for the approval of various antidepressants, 12 of them here. And each rectangle represents one study, okay? The studies above the red line were positive for the antidepressant. That is, the antidepressant was statistically superior to the sugar pill. Okay, the studies below the red line were negative. That is, there was no separation between the drug and the sugar pill. And you don't have to be a statistician. You can eyeball this and say, well, it's about 50-50 roughly. Turns out 51% positive, 49% negative. And you only need two positive studies, and our consumer advocate today, Kim Witzak, knows better than anyone because she served on these FDA panels that approve these drugs. You only need two positive studies to get an approval for as an antidepressant. You can have as many negative studies as possible, so there's an incentive to run studies until you get two. But this is what the FDA saw in their analysis. Okay, does that make some sense? Okay. This is what we saw in the journals. Those same 74 studies. Okay, now, what happened to all the negative studies? Any students brave enough to shout out what they think might have happened? Publication bias. They went into a file drawer, most of them, because the companies didn't have an incentive to publish them, because they didn't support the medication they were trying to promote. But that's not what happened to all of them. Some of those studies that were below the line appeared above the line in the publications. How did that happen? Well, it's through, back of a better term, manipulation of the data, taking a secondary measure that wasn't the primary measure, maybe a measure, an outcome that was found statistically by chance or whatever, or even sometimes excluding patients from the analysis for various reasons. But this is what consumers, what students, what doctors saw when they read the literature. So this also contributes to our belief that these medicines are in this case, 94% of the studies were positive in the published literature. Whereas the FDA analysis showed 51% were positive. And by their analysis, Turner's analysis and his colleagues, they found that the published literature inflated the perceived effect size, the statistical term, of the antidepressants by an average of about a third. Okay? Now, to add to this a little bit more of the human angle, 3,449 human subjects by our analysis. David and I wrote a letter to the editor, I think it was JAMA or New England, it must have been New England Journal of Medicine on this. 3,449 human subjects never had their data published because they went into a file drawer. And what did we promise these people when they participated in this study in the first place? That they would be contributing to science. We failed them, okay, in a big way. Worse than that, about 1,843 of these human subjects had their data positively spun to appear above that red line, okay? So this was a problem. This study, by the way, is not in a fringe journal. It did appear in New England Journal of Medicine, and very, very important, sort of eye-opening study. I don't know if it got as much exposure as it deserved, but does that make sense what I'm telling you here? Hopefully I see some positive head nods. Okay. All right, so let's move into to how far, rather, how common is depression? And I'm going to make sure I don't step off the stage, okay? Almost 10% of Americans 12 or older experienced a major depression in 2020. At least 20% of Americans will experience a major depression in their lifetime. Smaller percentage will be diagnosed with bipolar disorder, but they're out there. And we're talking, and the studies I'm presenting today all have to do with non-bipolar, what's been referred to as unipolar depression. 20% of the population experience at least some depressive symptoms at any given time. So in a crowd this size of about 200 people, that would be about, if I'm calculating this right, about 40 people, right, of you today feel sad or down or whatever. There's good news because there are options that I'm going to tell you about, but it's very common. It's been referred to as the common cold of mental health, maybe for good reason. About 11% of Americans aged 12 or older took antidepressants during that study period, 2005 to 2008. I'm sure the number's higher now, much higher. And about 25% of American women ages 40 to 59 are taking antidepressants. That's a huge number. And from my perspective, women are being disproportionately exposed to the risks of these medicines. And that represents that. Women are more likely, twice as likely as men, and this is found culturally to be diagnosed with depression. It affects millions of people, generates billions of dollars in revenue, and has been considered more costly than heart disease in multiple analyses. So depression is common, and it's costly. Okay, so let's dig into how the treatment. What treatments show effectiveness. This is an early study done in 1992 by psychiatrist Bruce Wexler at Yale. It didn't get much exposure, or it just is like a drop in the bucket from the marketing, which is so good. But this is the vertical axis is the percentage of patients. You can't really see the labels on the bottom there, but this is 7 studies. They put them all together, 513 subjects. And the bar on the far left is the drug therapy. The middle one is psychotherapy. Sorry, yes, and the other one is combined therapy. Okay, so antidepressant, psychotherapy combined. And they only included studies that had those 3 conditions. The patients were randomly assigned to them. Okay. And they looked at the ones that had a positive response, those are the bars on the left, and the ones that had a negative response. Okay, I'm taking some time to explain this because it's important to understand the pattern of results. In terms of a positive response, the medication conditions had the lowest positive response, and you can see visually, you don't have to be a statistician, that the psychotherapy alone and the combination treatment had similar outcome. Right? Negative response included a bad outcome. They didn't get over their depression, or if they dropped out, they considered that a negative response as well. So the most negative response occurred in the drug conditions, followed by combined, followed by the psychotherapy alone. Okay, are you getting the pattern here? This is an early study. And these authors at the time said, well, based on these data, maybe we ought to consider having a psychotherapy intervention be the first line of attack, because that way you are less likely, because the combination doesn't seem to be much better, and that way you're exposing people to fewer side effects and lower risk, right? That was the rationale for their conclusions. It went nowhere, I will say. Okay, and that's a long time ago, over 30 years, but it's a clue of what may be coming with subsequent studies. So I share this with you because it was an important first meta-analysis. So let's talk about some of the psychological options that have shown promise. This is a model we'll call the behavioral activation model, originally developed by Peter Lewinson at the University of Oregon. Okay, this was his theory, that depression results from a low rate of positive reinforcement. It was more than that. He said it resulted from a low rate of response contingent positive reinforcement. All that means is the person wasn't able to impact their environment so they could have some good experience, positive experiences. Okay, the things that could influence that rate of positive reinforcement included how many things the person found enjoyable, how available they were, and whether they had the social skills to get them. Okay, simple model. There's a negative feedback loop because he theorized that some people might even get reinforced for depressive behaviors by family and friends who mean well, but may only pay super attention when they're down and not when they're doing better. Okay, so that was the behavioral model that Lewinson developed. And this sounds trivial now, but at the time there had been no data to support this. But he found that depressed patients do have lower rates of pleasant activities, that mood co-varies with rates of pleasant and aversive activities, that mood improves when you get people to increase their pleasant activities, and that depressed patients often lack the social skills to get what they want, okay? Seemed common sense, but his data were consistently able to show these relationships. Now, trying to find balance is one of the challenges. This is the Workaholic Anonymous meeting. They'll be back in 4 minutes. Because as professionals and students and people of many backgrounds, finding that balance between doing what you enjoy and what you have to do and what might not be enjoyable and so forth is one of the challenges. And as we age, you have to be more creative about finding things you can enjoy. It says, we were thinking of having Grandpa committed, then one day he caught a 14-pound rainbow trout. And what is true, what Lewin's research showed, is if you enjoyed something as a younger person, there's a good chance you'll enjoy it later in life. And that maybe as we age, we do have to modify what we do, because maybe you can't, maybe you love to ride horses as a younger person, but maybe your back won't allow it now, but you can still be around horses, you can train horses, you can pet horses, you can watch your grandkids ride horses or teach them how. So a good clue for what you might enjoy later in life is what you enjoyed as a younger person. It says, when I found myself $46,000 in debt, I decided, what the fuck, that was enough success. And these slides are often designed just to trigger a thought for me. And this means that things that we think are supposed to be pleasant, like graduating or getting a job or buying a house or something, can also be stressful. And there can be a joyful component too as well. But you have to make sure that you pick things that you actually do enjoy to balance out some things we expect to be joyful but may not be, maybe more stressful than joy. So Lewin's research showed us that the most common activities that led to improved mood were these three. They call them mood-related activities in his factor analysis of the data he collected. Pleasant social interactions, competency experiences, doing a job really well, learning a new skill, fixing something, all have a mood boost. And things that are incompatible with depression, like laughing or going to a comedy show or something that's incompatible. These are the most commonly related mood-related activities. What can interfere with pleasant activities? Again, may seem obvious, but this is based on his research. Pressure from type A, work-related activities. Again, the pitfall that a lot of professionals fall into, all work and no play, not a good combination. Or a poor match between what a person actually enjoys and what they choose to do. I'll use an example from my own life. My wife, Yvonne, and I, and she's here today, we used to go to the opera together because she loves opera. Well, I was never exposed to opera, and I didn't have the background, and the truth is I didn't really enjoy it very much. And we went for a long time, and finally I said to her, do you think it's okay if I don't go to the opera with you? And she said, oh, no problem. I'll go with one of my girlfriends, and you can go see an Arnold Schwarzenegger movie. And that was perfect. Okay, now I was having a better match with my chosen activity with what I actually enjoyed. Okay, sometimes a change will remove the availability of a certain pleasant activity. Someone close to you might die, or you might move, or you have a job change or something. And so you have to pay attention that you still build in enough pleasant stuff. And of course, anxiety can interfere with potential enjoyability of certain activities. And so gradual exposure can help you overcome these, enjoy something you might enjoy. I mean, there might be some exceptions, like I have anxiety about bungee jumping, and so I guess I could practice rappelling or something as a way to get closer to being comfortable bungee jumping, but it's probably not something I'm going to do. But most things are a lot less extreme. Learning to make new friends, joining a social group, those kind of things could be done gradually to overcome the anxiety. All right. Again, data. I will try to explain this slide. This is a study by Demijan at the University of Washington. One of the co-authors was the father of one of my great colleagues, Dr. Barbara Kohlenberg. Bob Kohlenberg was involved in this study, as was Neil Jacobson and other folks. And what they did here is, and this was using the behavioral treatment, and the cognitive. Well, I'll tell you what they did. They randomly assigned 241 patients with major depression to 16 weeks of treatment, either medication, in this case it was Paxil, cognitive therapy, or behavioral activation, the kind of increasing behavioral pleasant activities I talked about. I'll talk more about cognitive therapy in a bit. Those are the three treatments. There was a placebo group. All three of these conditions were more effective than the placebo group at the halfway point, so they stopped it, the placebo group, for ethical reasons. And so here were these three groups. And the vertical axis is the Hamilton rating scale for depression, the response and remission rates, using the Hamilton scale to judge that. And the dark bar represents total remission. That group, that's the percentage of patients who are no longer meeting criteria for depression. These patients are thoroughly interviewed, and that's how they come up with the diagnosis, applying the DSM-4 criteria and the diagnostic manual. And the gray bar is the other patients who had a response but weren't completely over the depression enough to not get a diagnosis. Okay, and so again, visually, you don't have to be a statistician. You can see the advantage seemed to go to the behavioral activation group, right? Followed by the cognitive therapy group, followed by the antidepressant. Okay, and these were the results at 16 weeks. But what they did, which was interesting, and I'll try to explain this graph, is they followed these patients for 2 more years. And they started, and this just includes the patients who were no longer depressed, just the remitters. So you start out at the beginning, 100% are not depressed, and you follow them for 2 years. Okay, and this is called a survival curve. How many of those patients stayed not depressed over the course of those 2 years? And but with the antidepressant group, what they did is they split it in half. They randomly assigned them either to continuation of the antidepressant or a placebo. So half those antidepressant patients continued on a placebo. And the line that's deteriorating rapidly there, that's the group that got switched to the placebo after an extra year of being on the antidepressant. So basically 50% of the remitters, those who were not depressed, became depressed again. The other 2 groups, which was continued antidepressant or prior cognitive therapy or prior behavioral activation, those groups did not get any more treatment. Those 2, the antidepressant group did, because they had to meet with their doctors to continue the meds. You can see they had roughly comparable deterioration or survival over the course of that year. And in the final year, they took the patients off the continued antidepressant. Okay, and that's the deterioration you see in the steep line there. So these patients that had an extra year of antidepressants, then taken off, more than 85% relapsed. Again, the cognitive therapy group and the behavioral activation group did not get continued treatment, but they were much less likely to relapse. Okay, so that graph making sense as I'm kind of explaining it. I know they're complicated. Again, I feel this obligation to do this. They also looked at cost in this same study. This is interesting. And the first 16 weeks where everybody was in treatment, the costs for the psychological conditions were higher because they required more frequent contact than they did in the medication condition. And that's the triangle bar in the first 16 weeks there. You can see the costs were higher. But as I said, they stopped treatment at that point, and the costs became flat for those 2 psychotherapy conditions. But in the antidepressant condition, they continued treatment, and the costs became higher. And so they were trying to make the point that it's not necessarily true that the psychotherapy is going to be more expensive if you consider the outcome and the need for continued treatment. Okay? Makes some sense? The argument they're making. I'm not saying they're right, but this is what they were looking at and what they came up with. Okay, so let's talk a little bit about what cognitive therapy looks like. Cognitive therapy tries to address what are called cognitive distortions, thinking that might be not supported by evidence or a little bit out of whack with what's really going on. The most common, I'm very, very much simplifying cognitive therapy, but the most common cognitive distortions are these three. Overgeneralizations is one, where you use words like always or never. Okay? I'll always feel depressed. But as Dr. Healy will tell you, depression is a self-limiting condition. Even people with severe depression do recover from it. Okay? Or I'll never meet anybody that I care about as much as this last person I was involved with. Now, the problem with a thought like that is the only way you could know that thought were true would be if you had met everybody in the world or you had lived your entire life. Yet, what happens when we're depressed is we think a thought and we say, I think it, therefore it must be true. And cognitive therapy goes about trying to challenge those kinds of distortions. Perfectionistic thinking. For some of you students, I should have done better on that last exam. Well, maybe you haven't had any yet in Dr. Hinnan's class. Or I must get an A in this class. Those are highly moralistic words, and it almost feels like it's a moral imperative to accomplish that. It's been described as shooting on yourself or masturbation as a way to remember there's some distortion going on there. And the main strategy is to soften the language, okay? To use words like I would like, I prefer, I would like to get an A in this class, and I'll do my best, study as hard as I can to get a good grade, but I'm also human, and I can learn from the last exam, maybe, and do better this time. So softer language. Okay, catastrophizing. Words like awful, I can't stand it. I can't live without this relationship if it ends. As if it were like food and oxygen. And yet when you have that thought, it can seem 100% accurate. And so a cognitive therapist might say, well, was there a time before you met this person that you were alive? That's what David Burns would do. He always does it with a sense of humor. But was there a time before you met this person that you were doing okay? And so that thought that I can't live without this person, you look for evidence for and against, and try to come up with a more balanced thought. Yes, I will be, devastated, very sad if this relationship ends, but I will do what I can to engage with people and so on and so forth to get through it. So here's an example of catastrophizing. This is Dave projecting his worst fears. People who don't like Dave and those who are undecided. Okay. So if I were looking at this hypothetical patient named Dave, I would try to help him expand the little sliver that says yet undecided and look for evidence for and against. Does Dave have any friends? Does he do some things for fun? So on and so forth. And try to help modify this catastrophic projection. Because if Dave sticks with this, he's going to feel pretty bad. All right? I'm making a list of all the things that piss me off. Okay. And some people do have a list this long. And for them, it's very real. And so the challenge as a therapist is to try to help them add to their list some other things that might give it more balance, some things that they feel grateful for in their life, and so on and so forth. Okay, I'm simplifying this, but you get the idea. Some cognitions are so extreme that the natural consequence is you feel awful. Okay, and so cognitive therapy works to address that. Era of reduced expectations. If everything goes okay, that old left foot should be coming into view soon. Now, for someone who's very depressed, it might mean lowering the bar to such a level that they can have a success experience. For someone who can't get out of bed, it might be taking a shower and getting dressed. That's their goal for the day. It might be walking around the house or taking the dog for a walk around the house. It might be then walking to the park, gradually increasing the goal, but starting small so someone who's depressed can have a success experience and build on it. Okay? It says, don't be so hard on yourself. Let me do it. Okay. So again, that would go along with the perfectionistic thinking, and it's also so to soften the language, but also if there are people in your social environment who might be feeding into it, to address that as well. Okay. So it gives you an idea. It's a short version of cognitive therapy. Now, this is a really old study, but I'm including it for a couple of reasons. This was done by psychiatrist George Murphy at Washington University in St. Louis. The vertical axis is the Beck Depression Inventory score, pre, post, and 1 month follow-up, 12 weeks of treatment. This study was woefully underpowered. There weren't enough patients to really say much, but it has some interesting design features that I think are worth noting. Only 70 patients here. And again, you don't have to be a statistician. Patients were randomly assigned to, in this case, cognitive therapy, nortriptyline, which is a tricyclic, cognitive therapy plus placebo, or cognitive therapy plus nortriptyline. Okay, those 4 conditions. No stats needed here. You can see the outcome at post and follow-up were statistically equivalent. Okay, now they did something unusual in this study that's almost never done. They had what's called an active placebo. That is a placebo that had side effects. It was some combination, I think, of atropine and phenobarbital or something that would mimic, in theory, the side effects of antidepressants. Why would these researchers want to include a placebo that actually caused side effects? Any students out there who want to shout out an idea? Why would they include an active placebo, one that causes side effects? So it mimics the real thing, and you can't tell which condition you're in. It, in fact, makes it blinder. These studies are supposed to be double blind, triple blind. Nobody's supposed to know what condition they're in. We did a study here at the medical school where we had patients try to guess their condition. It was a placebo-controlled trial. And to a high degree, patients could tell what condition they're in, which can affect expectations. They're not really blind, despite the fact that they're portrayed as being blind. Does that make sense? And the reason you want them blind is because you don't want biases to slip in because of expectations about what's supposed to happen. Okay? So that's why I included this. But there was also another reason. And what these folks did is they followed these patients, no more treatments, but they followed them for a year. Here's another survival curve. Okay? Just looking at the patients who remitted at the end of treatment in that first slide, and starting with 100% remitters. They're not depressed anymore, just those who remitted. Follow them for a year, no extra treatment. And this is the percentage of patients remaining well, again, called the survival curve. The patients who got the tricyclic antidepressant had the lowest survival rate. Cognitive therapy plus tricyclics came next, then cognitive therapy, and cognitive therapy plus placebo had the best survival rates. What seemed to be happening is the antidepressants seemed to be pulling down the effects of the cognitive therapy, and the cognitive therapy seemed to be pulling up the effects of the tricyclic antidepressant. And to be fair, there weren't enough subjects to make this a statistically significant result, but it might have been a window into some things that I'll show you later. Okay? Now, mind you, this is over 40 years ago, these results were found. Okay, so even if you take the conclusion from the Wexler study and the Demizian study that the psychotherapies or the psychological interventions are as effective in the short run as the antidepressants, and maybe offer some protective value over the course of time. Even if you take that, well, what about surely for severely depressed patients, you would want to give them a pill. That's the general belief, right? I'm not saying something that's so absurd that people haven't heard before. Sure, therapy's okay for mild depression, but for severely depressed, it's not. What these guys did, and these guys really are the Rolling Stones of comparative research. Rob DeRubis and Steve Holland, I think, is at Vanderbilt. And anyway, they are Mick Jagger and Keith Richards when it comes to this stuff. They are awesome, amazing. But they, in this study, took the vertical axis is the response rate, and the response is defined as a Hamilton score of 12 or lower. And they randomly assigned patients to medication, cognitive therapy, or pill placebo. The medication was Paxil. There were 240 patients in this study. The Paxil could be augmented by dicipramine or lithium if necessary. That was done at the time because they were feeling like we want to try to mimic what's going out in the general practice. And so at 8 weeks, both the active treatments were better than a pill placebo. They stopped it for ethical reasons. The treatment went 16 weeks. Again, the statisticians out there will tell you it was equivalent outcome in terms of response rate at 16 weeks, even with these severely depressed patients. I think the criterion was at least 20 on a 17-point revised Hamilton scale, just to give you an idea what qualified to get classified as severe. So, but what happened over the next year? Okay. They took the antidepressant patients, randomly split them into continued antidepressant or pill placebo, okay? And they followed them for a year. The cognitive therapy patients did get 3 booster sessions. The antidepressant and the placebo conditions got regular visits with their doctor. And this is the percentage of patients who sustained a response from the original slide over the course of that year. If they were in the group that was switched to pill placebo, they had the lowest sustained response. Next came the ones who were continuing on antidepressants, and the highest sustained response came in the cognitive therapy group with the booster sessions. These results are and were surprising to people because, again, the general conventional perspective is for severely depressed patients, surely you have to use a pill. Well, there's some evidence here that maybe you don't. Maybe there are other choices. Again, emphasis on choice. Not telling people what to do, but here are the data to help inform that choice. This was published in the Archives of General Psychiatry, top psychiatry journal. These are not fringe journals. These are, England Journal of Medicine, Archives of General Psychiatry, Journal of Consulting and Clinical, some of the top journals in the world, Journal of American Medical Association, and so forth. Looking at it from the reverse side, what about a relapse of remitters? Just looking at all the remitted patients, how many relapsed? If they were in the group that had been switched to the pill placebo from the regular antidepressant, much more likely to relapse, followed by continued antidepressant, followed by the cognitive therapy group. Okay? Then we follow them for 1 more year, a naturalistic follow-up, no treatments for any of the conditions. And if they'd had prior continued antidepressant, in other words, for an extra year, they were much more likely to relapse compared to those that had prior cognitive therapy. Some evidence that there might be sustained, more enduring benefit from teaching someone some skills that they could use were they to fall into some kind of depression. Okay? Now, okay. So, original argument was maybe the therapies only work for mild depression. Shown evidence that they might be as good or better over the long term. What about for severe evidence, maybe as good or better? What about suicidal patients? Surely, if a patient is suicidal, surely you should offer them a medication, right? That would be the conventional perspective. And again, I don't think I'm talking out of line here when we say that's what is widely believed. This was a study done by Brown, published in the Journal of American Medical Association, one of the top medical journals around. And they actually went after the suicidal patients from an ER, and these were really serious. They had made an attempt at suicide, judged by very harsh criteria. And they the ones that they could recruit, within 48 hours, they had randomly assigned them either to cognitive therapy or enhanced usual care. And what enhanced usual care was intensive social work, marshaling of resources, and everything they could possibly do. Okay? And they followed them for 18 months. And this is the percentage of suicide attempts in each group. And statistically significant, clinically significant, the CBT group had about half the number of suicide attempts over the course of the next 18 months after the treatment. So even with suicidal patients, there's evidence that the psychological alone treatment can have benefit. Okay? And this is the last study I'm going to talk to you about. It's probably the most complicated to explain. Let's see. This is called the Treatment of Adolescent Depression Study, done by psychiatrist John March at Duke, I think he is. And this study is exceptionally well designed. They took 439 patients, adolescents, 12 to 18, who had been diagnosed with major depression, and randomly assigned them either to combined treatment, fluoxetine, which is Prozac alone, CBT alone, or placebo. Okay, so the vertical axis is the percent of patients who responded on a measure called the CGI, Clinical Global Impression Scale. Now, the use of this scale was a little bit controversial, and there are exchanges in the journal from critics like me. I wrote a letter together with Dr. David Burns, a psychiatrist who wrote Feeling Good, but there's other ones from various folks. But okay, what this found on this clinical global impression scale, using just part of the scale, just a dichotomized end of it, whether much improved or very much improved on a 7-point scale. This is only those 2 points depicted here. The combined group came out first, followed by fluoxetine, followed by CBT, followed by placebo. Okay? That's how they ranked. So live by the data, die by the data. This is one of the studies that's used to promote the idea that the combination treatment is the best option. Okay? But there was this was a 36-week treatment. So at 36 weeks, again, this is the outcome. You can see it. No stat analysis needed. The 3 treatments were equivalently effective at 36 weeks follow-up, okay? But there was a problem going back to the measure, because on the Children's Depression Rating Scale, which was the primary depression scale, there was no significant differences between the active drug and the placebo. This is the analysis that the FDA used in 2004 when they analyzed the TAD study. They did not count the TAD study as a positive study for Prozac because of this analysis on the primary depression measure. Okay. The placebo duplicated 86% of the response that occurred in the active drug condition. That piece of the pie left is not statistically or clinically significant, okay, by any analysis. And at the time of the hearings, Let's see what comes next because I don't. Okay. At the time of the hearings in 2004, I was grateful to be able to testify with Irving Kirsch. Kim was on the panel at the time looking at the suicidal risk associated with these medicines. And I'm going to come back to that. And before I do that, let me credit Dr. Healy with opening the door to the potential risk of antidepressants and suicidal behavior with a talk he gave in November, and I think it was 2000, in Toronto, where, in my view, that was the first time the risk was exposed in a public way. But I'll come back to that. So again, the same study, the TAD study on the Children's Depression Rating Scale for 1 year naturalistic follow-up, no continued treatment after the 36 weeks. You can see the treatments were equivalent at outcome, okay, over the course of the year, right? Vertical axis is the Children's Rating Depression Scale. Lower score is better, okay? So people did pretty well, right? At 5-year follow-up, that top curve is the percentage of patients who recovered or judged recovered, no longer depressed. 96% of the patients who participated in the original TAD study were judged not to be depressed 5 years later. So that's some good news. A lot of these adolescents who are suffering from depression and meet criteria for major depression are going to recover. And in this study, it didn't matter what treatment they got originally for the 36 weeks. Okay, that shorter curve there is a number of patients. About half of them had a recurrence that they later recovered from during that 5 years. Okay, again, kind of good news, really, don't you think? But what about the risk side of it? That's important too, right? You know, even if we're making the argument that the psychological treatments are as good, that doesn't mean they're necessarily something you should prefer over something else, but risk is important too. And from that same TAD study at the 36-week follow-up, this is the percentage of patients that had suicidal events during the 36 weeks. In the combination condition, the first bar, the CBT alone, and the fluoxetine had the highest rate, statistically and clinically significant, of suicidal events in this analysis. Well, that's not good. If the treatment is not necessarily more beneficial, if it's equivalent to these non-drug alternatives, the argument that Irving Kirsch and I were making at those hearings is, if there's no benefit, how can we justify taking any risk, even a little risk? But the FDA at the time, because they looked at all the studies, concluded the same thing, that risk was higher, and that's what led them to decide to do the black box warnings. And it's more complicated than that, but that's my assessment of the risk data were what caused them concern. Kirsch and I and Amanda Drews, a graduate student from this psychology department here, did a meta-analysis of all the antidepressant trials available at the time for kids. There were 19 of them. We found no statistical, we put them in the hopper, and it was not better than placebo. It was not statistically significant. Okay, so reflected what they found in terms of benefit. Again, harm, twice as likely in the drug conditions, and this is cheating a little bit because they combine the two fluoxetine conditions, the CBT condition, the two fluoxetine conditions and the two non-fluoxetine conditions, CBT alone and the placebo alone, but still twice as likely to have a harm-related adverse event in the group that took fluoxetine. Okay, that 2-to-1 ratio is exactly what the FDA analysis showed. 4% became depressed in the drug condition. This is thousands of patients put in the hopper. 2% became suicidal in the drug condition. 4% in the drug condition, 2% in the placebo condition. Twice as likely, but that's to put it in more real life terms, 2 extra suicidal patients for every 100 exposed to the medication. Okay? And so I put it this way, the risk is low, but the stakes are high. If it's you or your family member who is among those 2 extra ones for every 100 treated. And if you think about it, with millions of people taking it, those numbers can get high from a public health standpoint. Psychiatric adverse events from the TAD study. Much more common in the fluoxetine alone condition. Combination treatment brought it down a little bit. Placebo came next, but look how low it is for the CBT alone condition. And to put it in terms that, I don't know, make it a little bit easier to understand, it would take about 5 or 6 patients exposed to the fluoxetine to harm 1 extra one compared to had they gotten CBT. It's called the number needed to treat to harm. That's a term that some people use. Okay. So, what about non-psychiatric adverse events? These are the non-psychiatric adverse events that were more than twice as likely and statistically significantly more likely in the drug condition, fluoxetine versus placebo: sedation, GI problems, diarrhea, flu-like symptoms, insomnia, sinus problems, and vomiting. I mean, these ought to be considered also as information when you're trying to decide what treatment to take. So, these are my conclusions. You have to come to your own conclusions. Just because I conclude that doesn't make me right. And I am just touching the surface of the dozens, hundreds maybe of studies that look at this. I highlighted some studies because of their design to include here, but my conclusions are that psychological interventions are as effective as antidepressants when follow-up is at least 6 months, okay? Based on the data I've shown you. That psychological interventions teach skills to help prevent depression. You saw more enduring benefit, and the metaphor that, of course, I've used before is you can give a hungry man fish and feed him for a day, or teach him how to fish and feed him for a lifetime. So you're teaching people some skills that they can use when they're not feeling well, feeling emotionally unwell. And that the psychological interventions that based on these data ought to be considered an aggressive treatment option. They're not, or they shouldn't be, second fiddle. This is why I present these data, because I think they're seen as an afterthought, or again, only to be used for mild depression. I think the data contradict that, okay? I think it's an aggressive option. So I'll mention something that Steve Holland has been saying lately in his 2020 article that reviewed 50 years of research on cognitive therapy. It's worth reading. I think it's listed in the syllabus or the website, whatever it is, handout that we gave you. I think it's on the website. That emotional pain, he says, probably functions like physical pain. And that this adaptation theory suggests that depression is an evolved adaptation that served to keep our ancestors ruminating about complex social problems until they arrived at a solution. If true, then any intervention that facilitates problem solving is likely to be preferable to one that merely anesthetizes it. Does that make some sense? If in terms of physical pain, and people who cannot feel physical pain, if they touch a hot stove, they don't get feedback to take their hand off, right? So Holland is saying, this is a theory, it's not proven, but that he hypothesized that depression had some evolutionary value, and that it gives you feedback that you need to make a change of some kind in your thinking or behavior, or whatever. Holland also, I was surprised to see this in this article. It's in his article, but he says, based on the research that he's done, a lot of comparative studies with the Rubis and others, that if you remit in one of the various treatment options, you're least likely to relapse if you've had cognitive therapy or placebo. In other words, the placebo patients who remit are very unlikely to relapse. A little bit more likely with the SSRIs, more likely with tricyclics, more likely with the MAO inhibitors. This is his summary of the research. It's not mine. I can't vouch for the validity of it, but this is what he concluded, Steve Holland. There are other effective treatments that I don't have time to go into today that have been shown to be as effective, in some cases also have the enduring benefit that you see with the interventions I've shown you. Physical exercise, wonderful studies done on that. Social skills, assertiveness training, expressing yourself in a positive way, inviting people to join you, those sort of things. Having physicians or nurses teach patients problem-solving skills. Acceptance and commitment therapy, developed by one of our own, Steve Hayes, at this university. Bibliotherapy, using David Bone's book, Feeling Good, as a prescription for a patient who's depressed compared to no treatment, had statistically significant benefit. Other promising treatments, gardening for old people, who can't maybe do some other things in the nursing facility that they're in. Learning music, playing music, listening to music, all of these things have shown promise in comparison to drug treatments. So this is not meant to be anti-medication. Okay, this is meant to highlight the comparative effects of these choices that people have. Okay, people would take an antidepressant if they want. It's up to them. But it'd be nice also if they knew about this information when they were making that choice, right? That's my goal. This is pro-informed consent. We want to inform patients about the potential benefits and risks so they can choose. And I'm almost done. I feel like Karnak on the Johnny Carson show. People, hey, he's almost done. So the choice is this. Simple, but some psychological intervention alone, antidepressant alone, or combination therapy. They still have that choice. Nothing that I presented here takes that choice away from anybody. It's not meant to. Okay? It's meant to educate people on what the choices are. The problem is you're over-medicated. Luckily, there are drugs that can help you with that. Okay? So what often happens, we talked about it today in a podcast, is patients get medications added to their medications because of the side effects. It's called a prescribing cascade. Pills for the side effects of the pills, of the side effects of the pills, and so forth. And this is a serious problem. High percentage of patients are in this particular situation. I did a study with Dr. Jane Fisher, psychiatry resident Jeremy Matuzak, and Craig Urey, a psychology student years ago, Marcia Valenstein's a psychiatrist, where we looked at all the studies we could find with antidepressants that were augmented by a second drug. And we found 12 studies, and the analysis simply was that the combined or augmented condition was not statistically or clinically superior to the single drug alone. Okay? And of course, with more drug combinations, you have more risks. It says the Rogaine or the Viagra has to go. You don't know. There's unexpected consequences. So this is second to last slide. And I'm just going to explain this briefly. Because I've often been asked for me to give them a copy of my informed consent form. I don't do that anymore. I did that for years. I want you to create your own, for those of you who are providers. This is what I told patients on my informed consent form. I felt they had a right to know about my philosophy, my approach. It's not necessarily yours, but you can borrow it if you want. I don't care. You can use anything that's up here. I advise all patients to get a complete physical examination with labs before they come to me for treatment. Because at least 10% of depressions are caused by an undiagnosed, untreated medical problem. Okay? I tell them, I do not prescribe patients. I'm retired now, but this is what I told them. I tell them, I don't tell patients to stop taking their medicines. I'm not opposed to medication if the patient chooses. It's up to them. If a patient wants a medication evaluation, all they have to do is ask me. I don't routinely refer patients that came to me to see someone to evaluate for a psychotropic drug. Because of the data I showed you, I felt confident that what I offered was likely to be as effective. But it's still their choice. All they have to do is ask if that's what they want. That's on my informed consent statement. I'm not comfortable with the lack of science on combined medications. So, as I said on the podcast today, I stopped taking patients who had more than 2 psychotropic drugs on board at a time because I didn't want to enable something that I thought could possibly be dangerous, and it's outside my expertise anyway. And so I felt that was important. I referred patients who were taking benzodiazepines that they had a history of substance abuse. I referred patients who were on long-term narcotics. I worked in a chronic pain clinic. I knew the risks associated with long-term narcotics and the waning benefits over time. I referred patients who were dependent on alcohol because I didn't think coming to see me once a week was enough. If someone were truly dependent on alcohol, I was worried I could be enabling their addiction, so I would refer them to a more structured, perhaps more intensive program. I advise patients to consult a prescriber if they wanted to alter their meds in any way. Okay? I don't call medical doctors about the patient's medications. It's up to the patients. I work mostly with adults. If a patient wants to make a change, that's fine. But I'm not going to call the doctor and ask for the change. The patient has to take responsibility for that and do that. I will answer patients' questions about the published scientific literature, the stuff that I showed you today. I'm not afraid to tell them what the science suggests, that the psychological treatments are as effective in the short run and may have more enduring benefit based on the science, based on the stuff I published. But the choice of the treatment is ultimately up to that individual, okay? So these are the prescriptions I wrote. And that's what I have to tell you today. So thank you.